Assalamualaikum people. Today we'll have a peek at perforations of the bowel. Here are two bowel perforations, a duodenal perforation and a perforation of the small intestine. So let's dive in. Upper bowel perforations can be described as either free or contained. Free perforations occurs when bowel contents spill freely into the abdominal cavity, causing a diffuse peritonitis. For example, an anterior duodenal ulcer or an interior gastric perforation. Now, contained perforations occurs when a full thickness hole is created by an ulcer, but free spillage is prevented because contiguous organs wall off the area. For example, when a duodenal ulcer penetrates into the pancreas, here you can see this one here, and here the pancreas has stopped the spread of the intestinal contents. Now, the lower bowel perforations, such as in patients with acute diverticulitis or acute appendicitis, result in free intraperitoneal contamination, as we all know. Now, just a few words about the peritoneal cavity. It is lined with a single layer of mesothelial cells and connective tissue. The parietal peritoneum covers the abdominal cavity, that is the abdominal wall, the diaphragm, and the pelvis. The visceral peritoneum covers all the intra-abdominal viscera, forming a cavity that is completely enclosed except at the open ends of the fallopian tubes. So somewhere here. Okay. Now, the peritoneal cavity is divided by the transverse mesocolon, this one here, and the abdominal policeman, that is the greater omentum, extends from the transverse mesocolon, and here we have this transverse mesocolon and the stomach to line the lower peritoneal cavity. The pancreas, duodenum, and ascending and descending colon here are located in the anterior retroperitoneal space. The kidneys, ureters, and adrenal glands are found in the posterior retroperitoneal space. The rest of the organs are found within the peritoneal cavity. Okay, and this arrangement of organs and peritoneal folds directs the movement of spilled bowel contents and is of importance in the presentation and lateral abscess formation in untreated cases. Normally, the stomach is relatively free of bacteria and other microorganisms because of its high intraluminal acidity. Most persons who experience abdominal trauma have normal gastric functions and are not at risk of bacterial contamination following gastric perforation. However, those who have a pre-existing gastric problem are at risk of peritoneal contamination with gastric perforation. So let me do a drawing here, and here we got the stomach, and I'm getting quite good at drawing the stomach when doing it. Hopefully it's very good, not bad, only my duodenum is quite dilated. Anyway, if there is acid here, the leakage of this acidic gastric juice into the peritoneal cavity results in a profound chemical peritonitis. And if we have food, I'll do food in blue, and this also spills here, and when these particles reach the peritoneal cavity, this chemical peritonitis is succeeded by the gradual development of a bacterial peritonitis. So patients may be free of symptoms for several hours between the initial chemical peritonitis and the later occurrence of the bacterial peritonitis. The microbiology of the small bowel changes from its proximal to its distal part. So I'll just draw a small bowel here, and then we're going to go and my colon, I haven't been doing a good colon. So we've got the tinea here. Okay, this looks a little bit better. So few bacteria populate the proximal part of the small bowel, whereas the distal part of the small bowel, that is the jejunum and the ileum, contains aerobic microorganisms, that is the E. coli and Bacteroides fragilis. Thus, the likelihood of intra-abdominal or wound infection is increased with perforation of the distal bowel. The presence of bacteria in the peritoneal cavity stimulates an influx of acute inflammatory cells. The omentum and viscera tend to localize the site of inflammation, producing a phlegmon. So we got this omentum coming in here, and let's say we'll do this drawing here, and the appendix is inflamed here, for example, and this omentum then just sorts of isolates this walls of this acutely inflamed appendix. This also occurs in perforations of the large bowel as well, because the omentum is at the lower part. Now, the resulting hypoxia in the area facilitates growth of the anaerobes and progresses to an enlarging abscess. If untreated, bacteremia, generalized sepsis, and multi-organ failure and shock may occur. So all this pus, it's going enter into the bloodstream, and from there it would result in septicemia and so on. Now, in the etiology, the list is quite long, and the causes include penetrating injury through the lower chest or abdomen, for example, knife injuries. In cases of penetrating trauma, the small bowel is most commonly injured intra-abdominal viscus, because it is coiled in the abdomen and occupies most of the area of the abdomen. So if I do a drawing here, and we are going to be looking at the small bowel, so this in blue, it's all the small bowel, and if we draw the large bowel is somewhere here, okay, and it's just here and a little bit here, and we've got some bit of the stomach picking out from the underneath the costal margin. So if you look at carefully, most of the bowel, the small bowel, most of the area of the abdomen is occupied by the small bowel. In addition, the small bowel is also attached to the with a mesentery running from here to here, and this movement in blunt trauma causes injury. Now, blunt trauma is common in children. It's more common in children than in adults, and includes vehicle-related trauma, bicycle handlebar injuries, and seat death syndrome. Ingestion of aspirin, NSAIDs, and steroids is particularly observed in elderly patients. NSAIDs and H. pylori are responsible for peptic ulcers and peptic ulcer perforation. Now, prescribing NSAIDs to patients with diverticular disease carries an increased risk of colonic perforation. Predisposing conditions include peptic ulcer disease, acute appendicitis, acute diverticulitis. I have labeled these here in 3 here, and inflamed buccal diverticle. Indeed, acute appendicitis is still one of the common causes of bowel perforation in elderly patients, and is associated with relatively poor outcomes in this age group. Bowel injuries associated with endoscopy can occur with endoscopic retrograde cholangiopancreatography and colonoscopy. Endoscopic biliary stent dislocation and migration may cause bowel perforation. Here we have a bowel perforation due to a biliary stent. This has displaced, and it is abutting the duodenal wall. It's been taken out and with a grasping forceps, and here we can see the ulcer. This is a small hole here, and this has been closed with the 3 endoclips. It's a wonderful technology. Now, intestinal puncture may occur as a complication of laparoscopy. The factors that may predispose patients to this complication are obesity, pregnancy, acute and chronic bowel inflammation, and bowel obstruction. Bacterial infections, for example, typhoid fever, may be complicated by intestinal perforation in about 5% of patients. Perforation in these patients may unexpectedly occur after their condition has started to improve. In our country, we have TB to look at as well. Here you can see a enteric perforation in the ileum. Bowel perforation may occur in patients with acute ulcerative colitis, and perforation of the terminal ileum may occur in patients with Crohn's disease. Perforation may occur secondary to intestinal ischemias, for example, ischemic colitis. Now, bowel perforation can occur by intra-abdominal malignancy, lymphoma, or metastatic renal carcinoma. Even benign tumors such as desmoid tumors may cause bowel perforation. Here is a perforated adenocarcinoma of the colon. Radiotherapy of cervical carcinoma and other intra-abdominal malignancies may be associated with late complications, including bowel obstruction and bowel perforation. After a kidney transplant, because of the large amount of high doses of immunosuppressive medications, we might have a perforation of the bowel. Ingestion of caustic substances may be accidental or intentional and may result in acute intestinal perforation and peritonitis. Delayed perforation may occur up to around 4 days after acid exposure. And lastly, foreign bodies, for example, toothpicks may cause perforation of the esophagus, stomach, or small intestine with intra-abdominal infection, peritonitis, and sepsis. In children, small bowel injuries following blunt abdominal trauma are infrequent, with an incidence of 1 to 7%. In in adults, perforation of the peptic ulcer disease very common. These were a common cause of morbidity and mortality with acute abdomen after until the later half of the 20th century. The rate has fallen in parallel with the general decline in the prevalence of peptic ulcer disease. Duodenal ulcer perforations are 2 to 3 times more common than gastric ulcer perforations, and around 1/3 of gastric perforations are due to a gastric carcinoma. So what we would suggest is that you always take a biopsy of a perforated gastric ulcer. Approximately 10 to 15% of patients with acute diverticulitis develop free perforation. Although most episodes of perforated diverticulum are confined to the peridivertical region or pelvis, patients occasionally present with signs of generalized peritonitis. The overall mortality is relatively high at around 20 to 40%, largely because of complications such as septic shock and multi-organ failure. In elderly patients, acute appendicitis has a mortality of 35% and a morbidity of 50%. The major contributing factor to morbidity and mortality in these patients is the presence of one or more severe medical conditions coexisting with but predating the appendicitis. Now, endoscopy-associated bowel injuries are not a common cause of perforation. For example, perforations related to ERCP occur in about 1% of patients. Early diagnosis and prompt treatment improve outcomes. A stitch in time saves 9. So, advanced age, comorbids, malnutrition, and the nature of the primary cause of bowel perforation and appearance of complications increases the mortality. A careful medical history often suggests the source of the problem, which is subsequently confirmed by clinical examination and radiological study findings. A history of blunt or penetrating trauma is usually volunteered. Use of drugs such as aspirin, NSAIDs, or steroid intake, particularly in elderly patients, has to be elicited. Treatment for peptic ulcer disease or ulcerative colitis is usually identified by the history of the primary disease and the result of the past investigations if the patient brings them along with you. Now, symptoms suggestive of typhoid fever include fever, abdominal pain, abdominal distension, constipation, and bilious vomiting. With regard to abdominal pain, it is important to ask patients about the time of onset of pain, the duration and location of the pain, the characteristics of the pain, relieving and aggravating factors, and other symptoms associated with abdominal pain. In other words, a full history. A history of similar attacks may also suggest the etiology. Sharp, severe, sudden onset epigastric pain that awakens the patient from sleep often suggests a perforated peptic ulcer. You need to differentiate this from conditions such as cholecystitis and pancreatitis, which are also quite common. Now, painless perforation of a peptic ulcer can occur with steroid use. The presence of shoulder pain suggests the involvement of the parietal peritoneum of the diaphragm. In elderly patients, the possibility of perforated diverticulitis or a ruptured appendix should be considered if the pain is confined to the lower abdomen. Now, approximately 30 to 40% of elderly patients with acute appendicitis present more than 48 hours after the onset of the pain. Now, a delayed presentation is usually associated with an increased risk of perforation. So, elderly patients also may have minimal pain, hence the delayed presentation. In young adults with pain in the lower abdominal quadrant, consider a perforated appendicitis as a possible diagnosis. Acute appendicitis with sudden perforation is usually associated with illness of several arts. The pain is typically localized in the right lower quadrant of the abdomen, unless the disease process has progressed to generalized peritonitis, when the pain would be then all over the abdomen. In young women, in addition to ruptured ectopic pregnancy, also consider a ruptured ovarian cyst and ruptured tubo-ovarian abscess in the differential. Vomiting occurs, albeit uncommonly, in patients with the perforated ulcer. Vomiting is, however, frequently noted in patients with acute cholecystitis. In patients with appendicitis, pain almost always precedes vomiting by 3 to 4 hours, whereas the converse is true in gastroenteritis. Hiccup is a late symptom in patients with a perforated peptic ulcer. Here we have a 1 centimeter perforation of the ileum after a trauma, and note the typical pouting mucosa in this patient. Now, in the assessment, we are going to be assessing the patient's general appearance. We're going to take vital signs, assess for any hemodynamic changes. We'll take the blood pressure and pulse measurements in the patient in the lying and the sitting position, and noting any postural changes. Examine the abdomen for any external signs of injury, abrasions, or ecchymosis, and observe the patient's breathing pattern and abdominal movements with breathing, and note any abdominal tension or discoloration. In perforated peptic ulcer, patients lie immobile, occasionally with the knees flexed, and the abdomen is described as board-like. Here, Mr. Hamilton Bailey of the book Bailey and Love is sketched examining one of these such a patient. Now, carefully palpate the entire abdomen, noting any masses or tenderness. Tachycardia, fever, and generalized abdominal tenderness may suggest peritonitis. Abdominal fullness and doughy consistency may indicate intra-abdominal hemorrhage. Tenderness on percussion may suggest a peritoneal inflammation, and that's called a rebound tenderness. Now, bowel sounds are usually absent in generalized peritonitis because of the ileus. A rectal and bimanual vaginal and pelvic examination may help in assessing conditions such as acute appendicitis, ruptured tubo-ovarian abscess, and perforated acute diverticulitis. In considering the differentials, you have to differentiate between perforation and a non-perforation along the spectrum of a particular disease. For example, acute appendicitis versus a perforated appendix. Now, a CBC may reveal leukocytosis, though leukocytosis may be absent in the elderly patients. Elevated packed blood cell volume suggests a shift of intravascular fluid. Blood cultures for aerobic and anaerobic organism is indicated. Findings from liver function and renal function tests may be within reference ranges, or nearly so if no pre-existing disorder is present. Erect radiographs of the chest are recognized as the most appropriate first-line investigation when a perforated peptic ulcer is likely. However, in approximately 30% of patients, there is no free gas can be identified. Here we look at this. This is the free gas here now. Thus, an erect chest X-ray, PHST X-ray, is not sufficiently sensitive enough to rule out pneumoperitoneum in patients presenting with upper abdominal pain. Plain, supine, and erect radiographs of the abdomen are the most common first imaging steps in the diagnostic imaging evaluation of patients presenting with medical history and/or clinical signs suggestive of bowel perforation. Findings suggestive of perforation include the free air entrapped in the subdiaphragmatic locations. If the quantity of free air is great enough, its presence can be visualized on the supine radiograph of the abdomen, allowing clear definition of inner and outer surface of the bowel, wall of the bowel. The falciform ligament may appear as an oblique structure. Here we can see the falciform ligament extending from the right upper quadrant towards the umbilicus, particularly when large quantities of gas are present on either side of the ligament. Air fluid levels may be seen on erect radiographs of the abdomen in the presence of a hydropneumoperitoneum or a pyoneumperitoneum. Water-soluble contrast media administered orally or through a nasogastric tube can be used as an adjunct diagnostic tool to detect any intraperitoneal leak. In approximately 50% of patients, the perforation has sealed at presentation. For those who favor a non-operative approach, contrast radiology is a routine in the management of these patients. These x-rays demonstrate a pneumoperitoneum here and here and here. This chest x-ray is showing a regular sign as well, and this is due to the perforated duodenal ulcer, this one here. Sorry about that. And sometimes if we cannot see this gas under the diaphragm on erect views, we get lateral views, and this is a lateral abdominal view, and this is the anterior abdominal wall here, and this is a pneumoperitoneum here. So this all is a pneumoperitoneum. Now, and this one you can see, these are the mucosal, the walls of the intestine. Now the regular sign, also known as the double wall sign, is a sign of a pneumoperitoneum, as we've seen before. It is seen on abdominal radiographs when gas is outlining both sides of the bowel walls. So this one, it's here we can see that this is gas here and here. It is seen with large amounts of pneumoperitoneum, so it has to be around greater than 1000 ml of air. Now, pneumoperitoneum may be a result of perforation or recent instrumentation or surgery. A false double wall sign can result from two loops of the bowel being in contact with one another. So we've got this one bowel loop here, and then we've got this one bowel loop here, and we've got air in here, see, and we've got air in here, and this bit may appear to be as a double wall sign, but it's a false double wall sign. Now, localized gas collection related to bowel perforation may be detectable on an ultrasound, particularly if it is associated with other visible abnormalities such as a thickened bowel loop. The site of bowel perforation can be detected by ultrasound. For example, it can differentiate between gastric versus duodenal perforation, perforated appendicitis versus perforated diverticulitis. Ultrasounds of the abdomen can also provide rapid evaluation of the liver, spleen, pancreas, kidneys, ovaries, adrenals, and the uterus. So hyperdense shadows here associated with echogenic lines under the liver in Morrison's pouch, fluid collection over here, and a hyperdense echogenic line in the anterior wall of the duodenum representing the scar of a duodenal ulcer are seen in this ultrasound. CT of the abdomen can be a valuable investigative tool, providing differential morphologic information not obtainable with plain radiography or ultrasonography. CT scans may provide evidence of localized perforation, for example, perforated duodenal ulcer with leakage in the area of the gallbladder and right flank, with or without free air being apparent. They may also show inflammatory changes in the pericolonic, soft tissues, and focal abscesses due to diverticulitis, which may mimic perforated colonic carcinoma. CT scans may not provide definitive radiographic evidence of a perforated Meckel's diverticulitis, as this Meckel's diverticulum tends to get lost in the intestinal small bowel loops. This CT scan is of a 37-year-old woman with a perforated gastric ulcer. There is a focal defect here, and in the lesser curvature here, we can see this one here. This is the defect, and there is a surrounding mural thickening, and this is the wall thickening is seen in this area, and there's a small air bubble in the anterior peritoneal surface of the liver. Laparoscopy may significantly improve surgical decision making in patients with acute abdominal pain, particularly when the need for operation is uncertain. Peritoneal diagnostic tap with a syringe and needle may be useful in determining the presence of intra-abdominal blood, fluid, and pus. A peritoneal lavage or a DPL is more suitable, valuable in the presence of history of blunt abdominal trauma. The presence of blood or prurient material or the detection of bacteria on gram stain suggests the need for an early surgical exploration. Alkaline phosphatase concentration in the peritoneal lavage is a helpful and sensitive test that may be used to detect occult blunt intestinal injuries. A concentration greater than 10 international units per liter has been shown to be a sensitive and a reliable test in the detection of occult small bowel injuries. The mainstay of treatment for intestinal perforation is surgery. However, surgery is contraindicated in the presence of general contraindications to anesthesia and major surgery, such as severe heart failure, respiratory failure, or multi-organ failure. It is also contraindicated if the patient refuses the operation and no evidence of a generalized peritonitis exists. Finally, surgery is contraindicated if a contrast meal confirms spontaneous sealing of the perforations, for example, a perforated duodenal ulcer, and the patient prefers a non-surgical approach. Even though the treatment is primarily surgical, emergency medical care includes the establishment IV access here and crystalloid therapy in patients with clinical signs of dehydration or septicemia. The patient is kept nil by mouth, and IV antibiotics are started to those patients with signs of bloodstream infection. Antibiotics should cover aerobic and anaerobic organisms. The goals of antibiotic treatment are to eradicate infection and to minimize related postoperative complications. However, if symptoms and signs of generalized peritonitis are absent, a non-operative policy may be used with antibiotic therapy directed against gram-negative and anaerobic bacteria. Antibiotics have proven effective in decreasing the rate of postoperative wound infection and improving outcomes in patients with intraperitoneal infection and bloodstream infection. Metronidazole is typically used in combination with an aminoglycoside to provide gram-negative and anaerobic coverage. An adult dose is around 7.5 milligram per kg IV before surgery. Pediatric dosing is around 15 to 30 milligram per kg per day. And metronidazole is a pregnancy category B drug. Although gentamicin is not a drug of choice, it should be considered if penicillins or other less toxic drugs are contraindicated when clinically indicated and in mixed infections caused by susceptible staphylococci and gram-negative organisms. Gentamicin dosing regimens are numerous. The dose is adjusted on the basis of creatinine clearance and changes in the volume of distribution. Gentamicin is a pregnancy category C drug. Cephalosporins are used in combination with metronidazole for treatment. Dosage depends on the agent used. Tazobactam is a beta-lactamase inhibitor, and it's used in combination with piperacillin to treat serious intra-abdominal infections. Ertapenem is indicated for complicated intra-abdominal infections in adults and children older than 3 years. It's a carbapenem, which is again resistant to most beta-lactamases. And the dosing in adults and adolescents is 1 gram IV or IVM once daily for 5 to 14 days. Eravacycline is a synthetic fluorocycline antibiotic belonging to the tetracycline class. It disrupts bacterial binding, protein synthesis by binding to the 30S ribosomal subunit. We do know that. Okay, it is indicated in adults for patients or for the treatment of complicated intra-abdominal infections. Now, the goals of surgical therapy are to correct the underlying anatomic problem, to correct the cause of the peritonitis, to remove any foreign material present in the peritoneal cavity that might inhibit WBC function and promote bacterial growth such as feces, blood, bile, gastric or intestinal secretions. Now, when we are trying to correct the underlying anatomic problem, so let me do another drawing of the stomach. We are concentrating on the stomach. So the underlying anatomic abnormality in this problem, the underlying anatomic problem is this perforation, and this can be closed with a mental plug. Okay, a mental plug or sutured if there's something else, perforation in the bowel. Okay, so that is trying to correct the underlying anatomic problem. Treating the cause of the peritonitis. Now, once the acid and the food are here, we've got pus, and this pus is causing the peritonitis. So we are going to be taking out this cause by evacuating this pus. And if there is any foreign material, so if you have a perforated DU, perforated gastric ulcer, all the food is going to be spilling out into the peritoneal cavity. Personally, I have removed seeds of bindi and ajwain. And ajwain is very difficult to remove. It's very small seeds. It's very small seeds. And in our culture, if a patient has an abdominal pain, bade bude, they would say take some ajwain. So these patients present with ajwain, and ajwain is very small. It sticks everywhere in the peritoneal cavity. It's very difficult to remove, but you have to remove it because it's a vegetable material, and vegetable materials have severe peritoneal reaction. Now, preoperatively, correct any fluid or electrolyte imbalance, replace extracellular fluid losses by administering Hartmann's solution or similar solutions that has an electrolyte composition that is similar to plasma. CV pressure monitoring is essential in the critically ill and or elderly patients whom cardiac impairment may be exacerbated by the large fluid loss and large fluid input. Administer systemic antibiotics, for example, ampicillin, gentamicin, metronidazole, making a best estimation regarding the likely results. Nasogastric suction is required to empty the stomach and reduce the risk of further vomiting. Urinary catheterization is used to measure the urinary flow and assess the fluid resuscitation, adequacy of the fluid resuscitation. Administer analgesics such as morphine in small IV doses, preferably as a continuous infusion. Now, in the operative management, the management depends on the cause of the perforation. So we're going to be performing urgent surgery either on patients not responding to resuscitation or following stabilization and maintaining once we got this patient has maintained an adequate urine output. All the necrotic material and contaminated fluid should be removed and accompanied by a lavage with an antibiotic solution. We are going to be putting in a 1 milligram of tetracycline per 1 ml, and this is a tetracycline. Hopefully my spellings are correct. Now we decompress the distended bowel via a nasogastric tube. A laparoscopic or a laparoscopic assisted mini laparotomy surgery is also being increasingly performed, with outcomes comparable to those of conventional laparotomy. Experience and advances in accessories have enabled endoscopic repair of a significant number of intestinal perforations, such as iatrogenic perforations. We did see one duodenal perforation there. Now, management of such cases must be individualized to the patient. Here we can see a patient who's had this laparoscopy, and there's a bile stained fluid here, and this was due to a displaced stent, and that was a biliary stent. So endoscopically it was repaired, but if there is peritoneal contamination, then that has to be dealt with as well. Now, since the 1990s, laparoscopic closure of perforated peptic ulcer has been described. A laparoscopic surgery offers several advantages. First of all, a laparoscopic procedure serves as a minimally invasive diagnostic tool, so you can look at other things as well. Other benefits from laparoscopic repair are postoperative pain reduction and less consumption of analgesics, and a reduction in hospital stay. Also, a reduction in wound infections, burst abdomen, and incisional hernia due to shorter scars has been noted. Look at this huge scar here. Look at this huge cut here. Okay. Now, it also is reducing the incidence of postoperative ileus and chest infections. The drawbacks of laparoscopic procedure are a prolonged operating time, a higher incidence of reoperations due to leakage at the repair site, and a higher incidence of intra-abdominal collections secondary to inadequate lavage. It's a little bit difficult taking out all that fluid. Now, whether these fluid collections have any clinical relevance is unclear. The higher incidence of leakage might be caused by the difficulty of the laparoscopic suturing procedure. We've got to use very long needle holders. Alternative techniques to simplify the suturing process is like a mentoplexy alone, just put up the mento. Sutureless techniques have been tried. Fibrin glue alone or a gelatin sponge has been glued into the ulcer. The downside of these techniques is that they can be only used to close small perforations. In the postoperative period, the aim of IV fluid replacement therapy is to maintain intravascular volume and hydrate the patient. It is monitored by the CVP measurement and urinary output. Nasogastric drainage is performed continuously until drainage becomes minimal. At that stage, the nasogastric tube may be removed. Continue the administration of antibiotics commenced preoperatively, unless results of cultures taken at the time of operation reveal that the causative organisms are resistant to them. Now, the goal of antibiotic therapy is to achieve levels of antibiotics at the site of infection that exceed the minimum inhibitory concentrations for the pathogens present. So enough antibiotic must be present in the peritoneal fluid. In the presence of intra-abdominal infections, GI function is often impaired. Therefore, oral antibiotics are not efficacious and intravenous antibiotics are recommended. Analgesics such as IV morphine should be given continuously or in small doses at frequent intervals. In the absence of morphine, nalbuphine, tramadol, ketorolac, and paracetamol may be used. If no obvious improvement in the patient's conditions occurs within 2 to 3 days, a review of whether the initial operative procedure was inadequate or complications have occurred should be taken. So inadequate surgery could be like inadequate removal, you haven't performed a very good lavage, you've left some foreign material inside, like food materials, stools, whatsoever. Complications could be like if you've sutured a bowel and it has leaked, so a bowel has leaked. Now a search for super infections at a new site is also made. So if you put in a CV line or if you put in a catheter, there might be infection there, and this is resulting in the delayed recovery. Review of the dose of antibiotics should be made if it is inadequate or the antibiotics used do not provide adequate coverage for anaerobes and gram-negative organisms. Wound infection rates correlate with the bacterial load in the bowel. Hence, this complication occurs more often with colonic perforation, for example, perforated diverticulitis or appendicitis. The judicious use of prophylactic antibiotics has been demonstrated to reduce the incidence of wound infection in contaminated and potentially contaminated wounds. Here we see a case of wound failure, and we can see the proline that's been used. Now, wound failure is a partial or a total disruption of any or all of the layers of the wound, the operative wound, okay, and it may occur early, and that is known as wound dehiscence, and in late, that the wound seems okay, the patient is discharged, comes back a month or two later, and that is the incisional hernia. Now, factors associated with wound failure include malnutrition, sepsis, uremia, diabetes mellitus, steroid therapy, obesity, heavy coughing, hematoma, a hematoma with or without infection. Now, localized abdominal abscesses may develop. This is the infraperitoneal colic. This is the infracolic compartment, and here are the common sites of the abscesses. This is a appendicular abscess. This is a pelvic abscess, a paracolic abscess on the right side, and then on the left side. Note how the paracolic fluid on the right side over here can migrate up into this subphrenic space and also into this subhepatic space, while on the left side here this collection is prevented from doing so by the this ligament, which is the phrenico-colic ligament. Now, multi-organ failure and septic shock may also develop. Septicemia is, as we all know, is defined as proliferation of bacteria in the bloodstream resulting in systemic manifestations such as rigors, fever, hypothermia. In gram-negative septicemia with endotoxemia, leukocytosis or leukopenia, which is seen in profound septicemia, tachycardia, and a circulatory collapse. Gram-negative infections are associated with a much worse prognosis than gram-positive infections, possibly because of the associated endotoxemia. Renal failure and fluid and electrolyte imbalances and pH imbalances may occur. Gastrointestinal mucosal hemorrhage is usually associated with failure of multiple organ systems and is probably related to a defect in the protective gastric mucosa. For patients with divertical perforation, so we are talking about divertical perforation here. Those treated with a non-surgical approach, if the pain and fever settle within a few days, the patients can go home with a barium enema and sigmoidoscopy to be performed on an outpatient basis a few weeks later. Colonoscopy is performed if any doubt about the possibility of malignancy exists after barium enema examination. If the patient continues to be pyrexial and the pain does not settle or the lower abdominal mass is enlarged, ultrasonography and a water-soluble contrast may be necessary to rule out an abscess. If an abscess is visible on an ultrasound examination, it will be drained under an ultrasonographic guidance. If the infection process fails to settle despite the adequate conservative treatment, surgery is indicated, which could include primary resection, irrigation, and a primary anastomosis. Now, this concludes the lecture on intestinal perforations. Hopefully, you would have learned something from it. Allah Hafiz and stay safe.